Hi guys, Dr. Giller here. We have a guest lecturer who is going to do the first slides for us. Can you tell us your name, please?
Lola.
And how old are you, Lola?
8.
8. This is my granddaughter. And what grade are you in?
Second.
Second grade. All right. So let's start the lecture. Go ahead.
Vitamin B12 problems, intestinal pathology.
Pathology. Great.
Pernicious anemia.
Pernicious anemia.
Vitamin B12 deficiency. And a megaloblastic anemia.
Excellent. Anemia. Okay.
Pernicious anemia, aka a type of pernicious anemia. Classically described as an anemia that occurs secondary on an autoimmune attack against most commonly parietal cells.
Parietal cells. Okay.
More rarely other targets.
Great.
Pernicious.
Up here.
What predates the autoimmune attack?
Okay.
In some cases, PA develops following a previous neutrophil heavy inflammation, typically rages in the fundic region of the stomach.
Okay.
This damaging inflammation is thought to turn on genes and fundic glands which are not supposed to be on. Change the phenotype of the cells.
That's like the look of the cell. Very good. One more slide.
The immune system does not like the new look of the parietal cells and calls in the immune attack. Whenever the cause, the fundic region of the stomach and the fundic glands are immediately destroyed. Ultimately destroyed by the autoimmune-related inflammation with this passage of time.
Very good. They're not going to believe you're a second grader. That was awesome. Thank you very much.
You're welcome.
Okay. If you want to hang around, I'll keep going. All right. So did you guys get all that? All right. Great. So let's go to the next slide. So who cares about destroyed fundic glands? So what if the fundic glands are destroyed? Well, remember that parietal cells make, what do they make? That's the hipster guy, right?
Yeah.
Hip. So they make hip. So they make hydrochloric acid is the H, intrinsic factor, and the P is pepsinogen. So if you destroy those glands, you can't make the hipster guy anymore. And so you don't have hip, now you're in lots of trouble. And we know from the last lecture, without intrinsic factor, you can't absorb vitamin B12. And you're going to become deficient in vitamin B12. Do you like the hipster? That's a hipster, Google says. So what? So vitamin B deficiency is the most common cause of something called megaloblastic anemia. Folic acid deficiency or vitamin B9 deficiency is the second most cause of megaloblastic anemia. So this is where it starts to get a little confusing. So what's the deal with this megaloblastic anemia? It is one of the two main subtypes of the major heading, which is called macrocytic anemia. So there's under the major category of macrocytic anemia, there's a megaloblastic anemia, which we're talking about today, and there's non-megaloblastic anemia, which we're not going to worry about. So the megaloblastic anemia occurs almost always secondary to a vitamin B12 deficiency. However, a B9 deficiency or a folic acid deficiency can also do the same thing. Study tip, folic acid has 9 letters, B9, that's how you can remember folic acid. Another study tip, so pernicious anemia is like a third category down or a second subcategory. Pernicious anemia causes megaloblastic anemia. Megaloblastic anemia is a subtype of macrocytic anemia. So it's important to know that these three are all related together. Let's talk it over. So without vitamin B, well, you know the story here. Without vitamin B12, or no, you don't know the story. So without vitamin B12, you you can't perform hematopoiesis in the bone marrow. Remember, the bone marrow is where red blood cells and white blood cells and all the cells are made in the bone marrow. And a subtype of hematopoiesis is erythropoiesis. That's making of red blood cells. So if you have megaloblastic anemia, or if you don't, in other words, if you don't have vitamin B12, you can't run erythropoiesis. In other words, you can't make red blood cells. Is your body going to be happy if you don't have red blood cells? No. You're not. You're going to have anemia. You're not going to feel good. You're going to be run down. You're not going to have enough oxygen. So that's no good. All the pathways of hematopoiesis are affected. I'm not going to get into them all, but by far the one that's affected the most is the red blood cell pathway. All right. If you really want to get more into the weeds, how does vitamin B12 screw up the making of red blood cells? Vitamin B12 is needed for DNA synthesis. So, of course, we need DNA synthesis to make a red blood cell. So, it doesn't work. Interestingly, RNA synthesis is not screwed up. So these red blood cells have a weird kind of Frankenstein look to them. They have normal cytoplasm because cytoplasm is made by RNA synthesis, but because DNA synthesis doesn't work, they have a tiny little nucleus. So that's one weird thing about them. So you get all these weird blood cells, and you don't have to know this for me. You might know it already, but here's the pathway, and there's the making of red blood cells there. So if you don't have B12, you can't run this pathway very good, and you get all these, instead of getting mature red blood cells, you get these things called megaloblasts, and they're really weird looking. We'll see some real pictures here in a second. Who needs blood cells? Do you need blood cells?
Yes.
Yes, you do need blood cells, because red blood cells carry oxygen to every nook and cranny of your body, and all your cells need to have oxygen to survive. If you don't have enough oxygen, you get the symptoms of anemia. The big ones are tiredness. What's that word?
Tiredness is that you're like really tired.
Yep. And what's this? How about that word? That's a hard one to say.
Malaise.
Malaise. You know what that is? You know when you get sick, you don't feel good?
Yeah.
It's like generally not feeling good. And then because you don't have enough oxygen, your heart's going to try to make up the difference. It's going to beat really, really fast. And
if it beats really, really fast, it's not good.
That's not good. And that if you take someone's pulse who has anemia, they'll have a rapid and thready pulse. Okay, another problem, what else does vitamin B12? And this is, for us chiropractors, this is up our alley. So vitamin B12 deficiency screws up the remyelination of nerves. So we know nerves are protected by a myelin sheath, but that's not immortal. It doesn't live forever. That's got to be protected. And its replaced, its replacement is dependent on vitamin B12. If you don't have vitamin B12, the covering around your nerves is going to wear out. It's like a wire. If you take the insulation off the wire, you can start getting short circuits, and that's not good. Those short circuits can create some weird types of pain. You guys know what a neuropathic pain is? Do you know what neuropathic pain? You're in second grade. You shouldn't know. If you know what neuropathic pain is, I'm going to put you right into college. Neuropathic pain is a pain that doesn't follow dermatomes. It's kind of all over the place, or it skips around. It's on the outside of the foot one day. Next day you see the patient's on the inside of the foot, and it skips around. So that's a weird type of pain. How does this is getting a little harder. How does the nerve damage actually occur? Now, research isn't 100% sure, but here's what Robbins thinks and Woods thinks. So vitamin B12 deficiency causes a backup, and here's the take-home message, of something called methylmalonic acid, or MMA. And fatty acids get backed up too, but the big one. The problem is this. It's caustic to the nerve. It's damaging. It's like pouring gasoline on the nerve if this backs up. Normally, this isn't a problem because this methylmalonic acid is worked on by an enzyme, and vitamin B12 is a coenzyme, and it converts methylmalonic acid into methylmalonic coenzyme A, which goes on to make succinyl-CoA for the Krebs cycle. So that's a very important step. But if you cut out vitamin B12, this pathway is blocked. There's a beaver dam right here. And therefore, this will start to build up in the nerve cells and other tissues as well, the body. So that's the take-home message is this methylmalonic acid buildup is how we think nerves get damaged in people with pernicious anemia. Right, let's see, that's everything I said. Everything I said already. By the way, BTW, increased methylmalonic acid levels have been shown to have high sensitivity and specificity for making the diagnosis of vitamin B12. So you can order a blood test. I mean, this is kind of doesn't make sense because you could just order a blood test and see if vitamin B12 levels are decreased. But if you wanted to, you could also order methylmalonic acid, serum methylmalonic acid test to see what those levels are because they are related. These will be increased and vitamin B12 will be decreased. So that's a pretty darn good indication the patient has pernicious anemia. Making the diagnosis of pernicious autoantibodies. These are a board favorite. So people with pernicious anemia, they also typically show antibodies. In fact, there's 3 of them that you have to know that wreck the vitamin B12 reabsorption story in different places. Remember last week we talked about vitamin B12 reabsorption. Heptocorin, remember, came. I'm not going to go through the whole thing, but heptocorin was a player. Intrinsic factor was a player. Kabam receptors. Remember Batman? He hits the Joker in that cartoon. It's kabam. Kabam receptors. So there's autoantibodies which attack these important parts of the vitamin B12 reabsorption story. So let's go through them. There's an intrinsic factor, there's a Kabam receptor, sometimes called cubalin receptor, and there's another one that attacks the parietal cell, specifically the hydrogen potassium pump and the ATPase pumps of the parietal cell. So let's look a little bit more closely. Intrinsic factor autoantibody, that's often called a type 1 autoantibody. Make sure you know both of these AKAs because I use these interchangeably. So on the test, you don't know if I'll put that one or you don't know if I'll put that one. What does this autoantibody do? It goes after intrinsic factor as it's being made in the parietal cell. So in other words, it attacks parietal cells as well. But instead of attacking the proton pump system, it attacks the machinery that makes these parietal cells. And it destroys intrinsic factor. Specifically, it takes intrinsic factor's binding site and mutates it. So intrinsic factor can't hook up with vitamin B12, and we know that if vitamin B12 doesn't have intrinsic factor stuck to it and bound to it, it can't be absorbed into the body, and it goes right out into the toilet. Right? Patients can have a stomach upset. This is new. This is an error that used to be in Robbins that I caught. So Robbins said there was no stomach upset, but I double-checked this. This is not true, and it doesn't make sense because this is an autoimmune attack against the parietal cells. Even though it's not the proton pumps, it's still the parietal cells, so that can cause inflammation of the stomach. So patients can have stomach upset, which is called, what's that word?
Dyspepsia?
Dyspepsia from the inflammation. She's still hanging around, she's mesmerized. So by vitamin B12 can't, you know the story, vitamin B12 can't bind to intrinsic factor, and therefore it can't get into the bloodstream. So about 75% of patients with pernicious anemia have the autoantibody to type 1 autoantibodies. So you could do a blood test to test for this. Type 2 autoantibodies, another one, about 75% of the patients will have type 1 and type 2 autoantibodies. This one does not affect the stomach. So the stomach won't be destroyed, but it does hit the cubalin, aka CBAM receptors. So that's what it targets. If you inflame the CBAM receptors in the distal ileum, you can't reabsorb B12 and intrinsic factor. It goes through, ends up in the toilet. So you're going to be without vitamin B12, and you're going to have all megaloblastic anemia and all its sequelae. Okay? These patients will also have dyspepsia from a different source. It won't be the stomach, it'll be from the intestine. So still could present as dyspepsia, but it's more like abdominal pain. Okay, and the most common one is a type 3 autoantibody. So this one is in almost everybody who has pernicious anemia, and you can test for it. So this auto-3 antibody attacks the proton pumps, the hydrogen potassium ATPase pump. It attacks it for whatever reason. We don't know why it does. And so the parietal cells gets beat up again and inflamed, and that causes tummy upset. So if the proton pump is inflamed, you can't make hydrochloric acid. And that inflammation will spill over into the machinery that makes intrinsic factor, so you can't make intrinsic factor. And if that's not bad enough, we have our next door neighbor cells. What are those called?
Chief cells.
Chief cells. Chief cells, of course, make, you know that word?
Pepsinogen?
Pepsinogen. So without chief cells, you can't make pepsinogen. Without pepsinogen, you can't cleave the tail off and make pepsin. And so, yeah, so that absorption pathway is messed up there. How about some clinical signs? How do people early on with pernicious anemia feel? Well, pernicious anemia, they're going to have anemic type symptoms. They're going to feel weak. They're going to have malaise. They're going to feel fatigued. They're going to probably have dyspepsia as well from the inflammation. They're going to have a rapid heart rate, which is called, you know that one, Lola?
Tachycardia?
Yeah, tachycardia. Very good. With that weak and thready pulse. What else? Well, if they have demyelination problems with the nerves, those demyelination spots are going to create the signal of pain. There's going to be a depolarization. And so they're going to start having some weird pain in different areas of their lower legs or of their upper arms, or maybe even across the chest. It's going to be in a non-dermatonal pattern. And we said that's called neuropathic pain. Okay, they'll also have balance problems. Why would they have balance problems? You probably don't know this one. Especially if they close their eyes, but even if they have their eyes open. Well, it destroys myelin, so the posterior columns of the spinal cord are going to be out, and that's where proprioception is carried. So they're going to have balance problems as the disease gets worse. They're going to be more clumsy. Okay, what about if you stick a scope down their mouth and look inside their tummy? What are you going to see? Well, you might see some redness in the fundic region of the stomach. The accentic glands or the fundic glands are going to demonstrate destruction and inflammation. They're going to clinically have upset stomach, we already said. And we're going to study this next time. We're supposed to do it today, but I think you guys have had enough. We'll stop it there. But when you get an autoimmune attack against parietal cells, that causes a stomach condition in and of itself. So not only does it cause pernicious anemia, it causes stomach problem called chronic atrophic gastritis, aka autoimmune atrophic gastritis. So we'll get to that in the next lecture. Typical stomach juice findings. So now think about this. If they have type A pernicious anemia, parietal cells gone, so they're going to have no hydrochloric acid. So they're going to have either achlorhydria, meaning the acid is completely absent, or maybe they'll have a little bit of juice. That's called hypochlorhydria. And The chief cells are also involved, so they're going to have absent low levels of pepsinogen, and they're going to have no intrinsic factors. So you can sample, you can stick a tube down their nose into their stomach. You can sample their stomach juices and you can tell. There's another way you can tell they have this condition. So no hipster, no hipster. How about the blood work findings in pernicious anemia? So these would be the same blood work findings in someone with megaloblastic anemia. So they'll have vitamin B12 deficiency, so their vitamin B12 levels will be low. And just you don't have to hang around if you don't want. If you want to hang around, that's fine. She's still standing here on this lecture. Probably lost half of you guys already and aren't even listening anymore. I know some of you are. Lola's still listening. So we're going to have okay, now figure this one out. Why would we have hypergastrinemia? Why would we have hypergastrinemia? Well, if you don't have acid in your stomach, there's nothing to shut down the G cells. And the G cells run wild in remember the pyloric, in the pyloric region of the cells? We have pyloric glands. The star of pyloric glands is the G cell. That makes the hormone gastrin. It's shut off by high levels of acid or a lot of hydrogen ions or a low pH. But we don't have that in pernicious anemia. So there's nothing to shut down the gastrin, so gastrin runs wild. So you can take a blood sample and measure their gastrin levels to see. That would also confirm pernicious anemia. You can, back to the endoscope again, you can look down in the fundic region or the pyloric region of the stomach. You could look in that region and see that the G cells are hypertrophic from overuse, just like a bodybuilder lifting weights. If they're working all the time, they're going to get big and strong. And same with the ECL cells, which are being stimulated by gastrin to create histamine. So those are going to be bodybuilders. Those are going to be big as well. Now, the blood smear itself, they'll have a condition called pancytopenia. Pancytopenia. Oh, Lola got called away. So pancytopenia. So pan, what does pan mean? That means everything. That's like full thickness, pan inflammation. Cytopenia means little. So all the mature cellular elements of blood, especially red blood cells, will be low in the bloodstream. The bone marrow will be messed up as well. That's the first place we can see where this condition is taking root here. All right, macrocytosis. So that's another blood work finding they had. Okay, that's the same as megaloblastic anemia, right? We said the major category was macrocytosis. One of its subcategories was subcategory was pernicious anemia. Megaloblastic anemia was the subcategory of macrocytosis. All right, and we said that the red blood cells are much, much bigger than normal. So when you look in the blood, you're going to see these huge red blood cells, and they're going to have a nucleus. Red blood cells, we all know, don't have a nucleus, but these will have a nucleus. So let's look at, do I have a picture? I have a picture coming up. Let's finish this. Macroovalocytosis means abnormally large and oval-shaped red blood cells, bigger than lymphocytes. Anicocytosis, unequal size red blood cells. Poikilocytosis are abnormally shaped red blood cells. Hypersegmented neutrophils. Remember, neutrophils have 3 segments. Sometimes there's 6, 7, 8 segmented neutrophil, which is very strange. I'm not sure if you guys had blood work yet, or somebody talked to you about blood yet. Probably Dr. Doe, I would assume. But here's a normal blood slide right here. So here's a lymphocyte. There's a neutrophil with 3 lobes. So this is what your blood looks like, Lola. This is what's floating around in your blood. And then these are your normal red blood cells. they have no nucleus. They just have this pale region, which is what it is. But note the size of these red blood cells is small compared to the lymphocyte. Lymphocyte is much bigger, and so is neutrophil and basal cell, eosinophil, all those guys. So now let's look at someone with pernicious anemia. Or I could say, let's look at someone with megaloblastic anemia. Or I could say, let's look at someone with macrocytosis. Remember, you got to know those three kind of AKAs. But let's look at someone with pernicious anemia. There is a lymphocyte, and look at these gigantic red blood cells here. Now this slide, they don't show the nucleus. I think I have one coming up later. Well, you can see one nucleus here. You can see, no, they don't. This is kind of messed up. But the size of these things is huge. And look at the shape of these things. This one's like weird. This one's elongated. This one, I don't even know what you call that. It looks like a flower holder. What do you call a flower holder? I don't know what you call a flower holder. But they're all weird shapes. So this is an example of poikilocytosis, different shaped red blood cells. Got it? Okay, and then look at the neutrophils. So the neutrophils are hypersegmented. They're supposed to be 3. Let's count. 1, 2, 3, 4, 5, 6, 7, 8. That's very strange. So that's only seen in megaloblastic anemia that I know of. Bone marrow findings. So we have, here's a better example of someone with pernicious anemia. See the nuclei are right here. That's all cytoplasm. So RNA synthesis makes the cytoplasm. DNA synthesis makes the nucleus. And these are underdeveloped nuclei. I think that other slide, it was so advanced, the nuclei didn't even develop at all. But enlarged erythrocytes are found in the bone marrow because we said that's where all this stuff is made. And when they're enlarged, they're called megaloblasts. Megaloblasts. Usually they stay in the bone marrow at the start of the disease, but as the disease progresses, these immature giant blood cells get kicked out into the blood, and these are megaloblasts out here. And they have too much, well, it's not that they have too much cytosol in the nucleus, but they don't have, their nucleus is small, too much cytosol away from the nucleus, but the nucleus is small. So that has a word, of course. That's called nuclear cytoplasmic dissociation. Nuclear cytoplasmic dissociation. That goes with pernicious anemia. Make a note card so you remember that one. Why does pernicious anemia mess up red blood cells? Because it interferes with DNA synthesis. And MMA backs up if you really want to get technical. How about neurological findings in someone with pernicious anemia? Well, this might be the first, you may first catch the diagnosis with neurological findings. In fact, if they haven't had blood work, they may come into your office thinking they have sciatica. And once you start doing the history and do the exam, you'll say, oh boy, we better get some blood work because they don't have sciatica. And in more advanced cases, they can have damage to the brain. They can have lesions in the cerebellum and lesions in the cerebrum and different places. About 75% of late cases get permanent brain damage from this. So got to catch this early. And they may come into your office first because of thinking they have sciatica. More specifically, it's not a sciatica. Well, how do you know it's not? Because when you examine their dermatomes, they don't have a loss of sensation in the S1 or the L5. They have their entire leg is absent of sensation. So it's said that they have symmetrical dysesthesia. That's a good word. You want to say that one, Lola?
Dysesthesia.
Good job. Got a good memory, too. Symmetrical dysesthesia, which means they have the symptoms are mirrored on the right versus the left. So symmetrical dysesthesia. And dysesthesia is a pain, it's tingling, it's burning, it's numbness, etc. Why is this occurring? Because they can't replace the myelin. The wire around the nerve is gone. So they're getting short circuits. Really, why is it happening? Because MMA buildup inside the nerves is the current theory. What about differential diagnosis for extremity dysesthesia? This is a take with you for the rest of your life slide. You will have to keep this in your noodles forever when you get these complex cases with someone with widespread pain. So it's not always pernicious anemia. And I, even in my practice on the weekends, I order this stuff all the time. You always have to think multiple sclerosis can present with a symmetrical dysesthesia. Lyme's disease, this is what I test for. Lyme's disease, multiple sclerosis, small fiber neuropathy, from especially if they're diabetic and they don't take good care of their diabetes. Maybe it's the kind of nebulous chronic pain syndrome or widespread chronic pain, which we kind of used to think back in the day that, God, these people, maybe they should see a psychologist. But nowadays there's a lot of lab findings that show they are feeling the pain. For example, substance P is built up like crazy at the synapses in these patients. I won't go into the weeds on that. And maybe they just have a herniated disc and they got bilateral leg pain, but you should be able to tell that apart. And then Guillain-Barré syndrome is rare, caused by a virus, but that's got to be in the differential diagnosis as well. How about neurological findings on these patients? Make sure you know these words. They're going to have well, you tell me, Lola, what's that say?
Ataxia.
Ataxia, good. That's a loss of coordination of movement, especially if they close their eyes, so they walk with a wide gait and they're clumsy. They may have some muscle spasticity, so they can't walk. Maybe their calves are all cramped up, or their Tom, Dick, and Harry muscles are all cramped up. They may have upper motor lesion signs, like Babinski's and Hoffman's test might be positive. Those tests will never be positive in anybody with a simple disc herniation. Romberg's test, maybe, I don't know if you guys know that one yet or not. I do that one all the time on patients through the camera. Stand up straight. Okay, let's do it, Lola. Stand up straight. Put your feet together. Now close your eyes. Lola's not wobbling. Thank you. So if somebody else did that test and they had damage to the dorsal part of the spinal cord, I would have to catch her, or you would have to catch them, because they would literally fall over. Because if you close your eyes, there goes your cerebellum, which is the ultimate proprioceptive organ. But if you close your eyes, how does your body know where it is in space? It's because of all the proprioceptors in the joints and muscles, and the wires go up the posterior spinal cord. Memory loss, dementia in the severe phase. So there's some pretty severe findings, which all could have been prevented if you or whoever, their primary doc, if you would have caught the vitamin B12 deficiency, you could have prevented this. Other causes of megaloblastic anemia, folic acid deficiency, we said that already. Certain medications, why do I have wine bottles in here? Because drinking, you have to drink a lot of wine. You have to drink a bottle of wine a day for probably a year. But if you drink a bottle of wine a day for a year, you can that can screw up the production of red blood cells in the bone marrow. It can mess up hematopoiesis, and you can get megaloblastic anemia for overconsuming alcohol, and a whole bunch of other drugs for that matter. Diseases that interfere with DNA synthesis could be another cause. HIV virus is notorious for causing this, and some nasty disorders like cancers of the blood, like leukemia, things like that. How about some associations? So because pernicious anemia is an autoimmune attack, it's not uncommon for these people to have other autoimmune problems, like type 1 diabetes mellitus, like Hashimoto's disease, that's hypothyroidism. Vitiligo, like this person. What do you think of this? Look at that. So that's an autoimmune attack against melanocytes. And melanocytes live in the skin and give you your color. So her melanocytes are damaged.
So they're damaged, so they're just putting in random colors.
Yep, well, that's your default color right there. If you don't have any pigment injected in you by these melanocytes, That's your default color. Even though this is a person of color, she's white because we all really have the same skin. They just have more pigment. So it's autoimmune. So that's called vitiligo. Vitiligo. It's weird how it's so symmetrical. We'll talk more about that in dermatology in 7th quarter. Other associations, gas. Here's a bad one. So untreated, these patients can get cancer. So gastric carcinoma, the chance of that increases by 26.4 fold increase. So that's not good. Another reason this needs to be treated. Can you go shut that door for me, Lola, please?
Sure.
You can hear the other grandkids running wild. Thank you. Here's another one. I always ask this on a test. So about 25% of the patients with pernicious anemia, they have iron deficiency anemia. Iron deficiency anemia, Lola, what's that say?
Number of one type of anemia.
Yep. It's iron deficiency anemia is the number one type of anemia. We don't know why, what the association is. But anemia is anemia. You have messed up hemoglobin, you can't carry oxygen, and you get those symptoms of anemia. There's the one you were looking at before.
Mm-hmm.
So you can also have an autoimmune attack against your tongue. And it makes the tongue look like this. That's called a bald tongue. It's lost all the markings and the papillae in there, and it's red and inflamed. That's called atrophic glossitis. Atrophic glossitis, and that's an autoimmune attack. Your own body is attacking your tongue. Another picture of it. Okay, we got about 10 more slides, I think. Other causes of vitamin B12 deficiency. So it's not always an autoimmune attack. Remember vitamin B12 deficiency, sometimes we called it type A pernicious anemia. Well, there is a type B pernicious anemia, and I like to think B for, what's that word?
Bug.
For bug. So this is probably caused by the dreaded, the feared H. pylori infection. Most common cause of stomach upset is an H. pylori infection. That falls under a class called atrophic multifocal gastritis, which we'll talk about in the next lecture. So this is a bug infection of the fundic glands themselves. So what's the story with this bug infection, this type B for bug, pernicious anemia? So the bug gets into, inflames, and destroys the parietal cells and the chief cells. In fact, the whole fundic gland is destroyed. It may get to the pyloric glands as well in more advanced cases. If you destroy parietal cells and chief cells, I mean, there goes the hipster guy, right? So no hydrochloric acid or decreased hydrochloric acid, decreased pepsinogen or no pepsinogen, decreased or no intrinsic factor, that's the hipster. And then the maybe even confusingly decreased levels of gastrin. If it didn't get into the pyloric region of the stomach, your gastrin levels would be high. But if it did hit the G cells and inflame them, then your gastrin levels will be decreased. So be careful. That's kind of a confusing point. Additional blood testing in people with type B pernicious anemia, they will have no antibodies, not type 1, type 2, or type 3. No, none of those will be present. You'll find decreased levels of B12, just like you would in type A pernicious anemia. They still have megaloblastic anemia. So the blood smear, we have overlobulated blood cells, overgrown and irregularly shaped red blood cells, as we said already. Here's the third type of pernicious anemia. This one's called malabsorptive pernicious anemia, and there's a lot of members to this family. So many conditions can interfere with vitamin B12 absorption, from problems with heptocorin, and now you have to go back to that lecture. That's why I gave you the lecture, that in-depth lecture on how vitamin B12 is absorbed. But you can have gene mutations, so you don't make a proper heptocorin, CBAM receptors. So all these things are collectively called malabsorption pernicious anemia. Not an autoimmune attack, though. Autoimmune doesn't fall into this category. So an intrinsic factor deficiency can also lead to type B pernicious anemia. Now I hear you going, hey, wait a minute. You said an autoimmune attack against the parietal cells could cause a intrinsic factor to be mutated and messed up. Yep, but this is not an autoimmune type attack. Okay, this is a gene mutation in the gene that makes intrinsic factor. So there's no inflammation, nothing's under attack. The person was just born with a mutated machinery, so they can't make intrinsic factor. Okay, but it will do the same thing. If you don't make intrinsic factor, you're going to have vitamin B12 deficiency. You're going to have megaloblastic anemia, or you could say you're going to have macrocytic anemia. There's those three again. So make sure you know those. When you test for autoantibodies, they're not going to have any autoantibodies because this is from a mutation. All right. The stomach lining's not going to be damaged or inflamed because there's no attack. This is just a mutation and they can't make intrinsic factor. Endoscopic evaluation of the stomach, normal. Right? There's also proton pump mutations that could fall under this category. They're very rare. But if it's a mutation, you're not going to have an inflammation. They're not going to have an upset tummy, but they're still going to have pernicious anemia. They're still going to have hypochlorhydria, achlorhydria, and hypergastronemia. Got it? Proton pump mutations continued, everything we said. No hydrochloric acid, no vitamin B12. You remember how that works? Remember, we need hydrochloric acid to make pepsin from pepsinogen. And we need pepsinogen to break loose the food-binding protein from vitamin B12. Right? So that will allow heptocrin to latch onto it. Right? Another cause of pernicious anemia, this malabsorptive category of pernicious anemia, pancreatic insufficiency. So something, we've heard this before, right? EPI, hear it on the radio commercials. It's pretty darn rare. Talk to your doctor about EPI. It's super rare. So something, but it can occur, and this means something's wrong with the exocrine. That's where I'm going to trick you, right? On the test, I'm going to put endocrine function. It's got nothing to do with the endocrine function of the pancreas, right? That's insulin. That's glucagon. Exocrine function, that's the pancreatic proteases. That's trypsinogen. That's chymotrypsinogen. So if you have something wrong where you can't make trypsinogen or chymotrypsinogen, you can't break heptocrin from intrinsic factor, or heptocrin from vitamin B12. And heptocrin will keep vitamin B12 as a partner and go all the way into the toilet. Remember, that's got to be broken off so intrinsic factor can bind in the small intestine. Right? With this condition, there'll be no hypergastronemia. There's nothing wrong with the acid here. There'll be no hypochlorhydria. The stomach is working just fine. This is a problem further on down with the pancreas. Crohn's disease. Everybody's heard of Crohn's disease. Crohn's disease can also cause pernicious anemia, this malabsorptive pernicious anemia. So Crohn's disease, as we might get to later on, is an inflammation, perhaps an autoimmune attack. It's still debatable what causes it, but it's an inflammation of in particular, the distal ileum. Now that sounds like trouble, doesn't it? Because we know CBAM receptors live in the distal ileum. And so if you get an inflammation of the CBAM receptors, they're not going to catch intrinsic factor in B12. It's going to go right through and into the toilet. Okay, so make sure you know this. There will be no hypergastronemia. The stomach all that machinery is fine. There's no achlorhydria. There's no hypochlorhydria. Everything is just fine. Another MPA, parasites. Look at that, Lola. What's that thing? That's called a tapeworm.
What does it do?
They get that down. It lives inside your intestine and it eats your food, and you get really skinny. We don't have that in our country, though. But if you go down in South America, you could get a tapeworm, or the official word for that is cestoda. And cestodas, they love to eat vitamin B12 and intrinsic factor like candy, like cupcakes. They'll eat it all up. And so in this case, there's nothing wrong with any of your machinery. It's just this darn worm eats
How do you get it out?
all the vitamin B12. Antibiotics can kill it. You can take antibiotics, a special, very strong type of antibiotic. That's a very good question. And it'll kill it, and it'll go out in the toilet. It'll end up. Once you figure out what it is. It's not dangerous in and of itself. Okay. So again, with a parasite, there's not going to be hypochlorhydria. There's not going to be hypergastronemia. There's not going to be achlorhydria. Stomach is working just fine. All right, I think that's enough for your brains. Lola, do you think that's enough for their brains?
Yeah.
This will be the cutoff for the test, or do you
Yeah.
think we should be mean and give them more?
Let's stop.
Let's stop. Okay, so Lola says stop. All right, we'll stop right here. This will be the cutoff for the test. Email me those questions. See y'all later.